Good morning, good afternoon, good evening, wherever you are, and welcome to this new edition of the Ifso Journal Club. We're delighted to have Dr. Ido Arts from Rijnstad Hospital, Netherlands. Welcome, Dr. Ido. And
Thank you. Thank you.
we're going to be talking about an important topic, which is multivitamins and sleeve gastrectomy, which is still controversial in a lot of people's minds. It's very important to talk about it, and the mission of IFSO to continue throughout this tough world crisis of the pandemic. So delighted to have you all within these tough times. And before we start, I'd like to launch a few polls to get the sense of the use of multivitamins in sleeve gastrectomy patients. Manuela, can we launch the first one? So, do you think sleeve gastrectomy requires less or more multivitamins and mineral supplementation compared to gastric bypass? We'll take a minute to answer this question. And I know your answer, Dr. Ido, but what do you think the sense and the common use of vitamins in sleeve gastrectomy worldwide?
Well, thank you, Ahmed, for first of all, a nice introduction. The thing is that we've been doing research on this subject for the last 10 years, and I must say that luckily opinions do change once you provide sufficient and good information to your colleagues. In 2010, when we started off with this, the initial reaction of most of our colleagues was that either patients after a sleeve did not require anything in terms of micronutrients or multivitamins. And nowadays I see a significant change. So luckily, more and more of our colleagues do at least advise multivitamins to sleeve patients. So it is changing. It is changing, Ahmed.
Great. And we'll show the results. 85% think that sleeve gastrectomy require less vitamins than gastric bypass. So let's launch the second poll, Manuela. And I know, Ido, your group is contributing a lot to the science of bariatric surgery with lots of randomized controlled trials. And your opinion would be to give sleeve gastrectomy patients lifelong multivitamins, right?
Well, as far as we can see now, the biggest issue with the information that we now have is that there's relatively little long-term results for sleeve patients for their micronutrient levels. But what we do know is that even after a few years, average levels drop. So in our opinion, we see after a few years, even more and more patients getting deficiencies, and not just one, but multiple. So in our opinion, you should advise your patients to take them the rest of your life, indeed.
Great, and we'll share the results, and 81% agree with you. Still 19%, which is a good percentage, think that lifelong multivitamins is not required. So let's launch the last poll, which is, do you give vitamins, mineral supplements after sleeve gastrectomy? If yes, which supplements do you use? And what is the recommendations within your practice, Ido?
Well, what we used to do when I worked in the Rijnstad Hospital, it was a specialized multivitamin that I'm going to talk about in the next few minutes, of course, combined with additional calcium vitamin D twice a day, so 500 and 800 international units of vitamin D. And where necessary, for in case patients, for example, preoperatively already showed vitamin D deficiencies, up to 25,000 units of vitamin D a week using cholecalciferol.
Yeah, that's great. And I think we can only select one of the following. That's why probably the audience will not be able to select multiple, but let's show the results, Manuela. And 67% would supply standard multivitamins tablets. Still additional people selected other, but probably due to the technical issue. So
right.
So let's start. Edu, please.
Thank you, Dr. Ahmad. Well, first of all, everybody here, welcome also on my behalf and on the Ifso Academy behalf. So let's get this to work. Let me see. Yes, there we go. So once again, I'm delighted to be here and to talk to you about something that comes close to my heart, and be able to tell that to so many colleagues all over the world now. I can see how many of the attendees already are in here, and it's staggering how many people want to know more about a study that we performed in the latter years. I was asked to tell you something that was put online in November 2019 and is in the current issue of Obesity Surgery, and it actually tells you something that we didn't expect to find. What we intended to do with the study was actually to look for the best content of a multivitamin for patients after sleeve gastrectomy, but what we did find was a staggering number of deficiencies in general. So that's what we mean with the true story. And I must say, this study has been performed in the Rijnstadt Hospital, the Netherlands, as I already told you. And I'm much obliged to the first author, Laura Huizen, who did a lot of work for this nice publication. So first of all, let's go back to the basics. And we go back to a very important publication from 2018 that reports on the worldwide incidence of bariatric surgery. And if you would divide the surgeries into 3 groups, so gastric bypass surgery accounting for 30% worldwide and other types for 16%, on average, nobody will ever doubt that these types of surgery, so that's not only Roux-en-Y, but also omega loop, PPDDS, SADIs, etc., will require multivitamins to prevent deficiencies. But this is actually the case in 2016, 54% of patients undergoing a gastric sleeve, and these days that percentage has even risen to 70%. So the majority of patients for the latter years have gotten a gastric sleeve. Now, a gastric sleeve, in my mind, is a fine operation if you want to deal with morbid obesity. But if you do change the anatomy from a gastric stomach to a gastric sleeve, you also come across complications. Although the weight loss might be nice, people do suffer from GERD, but me being a sort of researcher in the micronutrients field, look at different things also. Perhaps the biggest complication is micronutrient deficiencies, and these are the cause of the gastric sleeve itself. If you just look at food intake, we know that after a gastric sleeve, 1/3 of food intake is reduced. And also, the time it takes food to pass through that narrow tube sometimes gets a little bit higher, sometimes it takes a little bit longer, but on average, it'll take less time for the food to pass through and get into the duodenum. Also, if you look at the total amount of gastric acid produced before and after a gastric sleeve, the amount of gastric acid is significantly reduced. And if you look at substrates that you need to carry, for example, vitamin B12 into the serum, those are reduced as well. So if you take all these into account and look at it at a theoretical point of view, any micronutrient that you normally would require in large volumes to ingest to get the right levels might become a problem. but most of the vitamins and minerals we know are bound to a substrate. And if you, for example, look at iron, you will need gastric acid in enough quantities to get that released from a substrate. And also, once that has occurred, some of the vitamins and minerals require a carrier to get it into the blood serum. So in theory, there's a lot that can go wrong in terms of micronutrients after sleeve gastrectomy. So doing a lot of research with over 70 publications currently, we do look at PubMed and Medline on a regular basis. The last time was in 2019, so this has directly nothing to do with the current study. But if you look at deficiencies or micronutrient deficiencies after bariatric surgery, you will find approximately 900 articles concerning this subject. And if you look at the abstracts, there are still 121 that are interesting. And you can put those during a second view in all sorts of tables to come up with something to prevent deficiencies to occur in a 1 pill a day regime that makes compliance better, in our opinion. So what we did in this study is take the same cherry flavored capsule and put the same basic ground materials in it. But in the one capsule, we put in 100% RDA, so what is on average in an over-the-counter tablet, and what was advised in those days by, for example, the ASMBS. So vitamin B1, folic acid, B12, iron and vitamin D, and all the others that are in a regular multivitamin are in there for 100%. Now, based on the literature and the research we did ourselves, we came up with an optimized 4. Same ground materials, but with different amounts. So for example, the vitamin B12 was in there for 400% instead of the 100%. Now, although these average differences might be small in some cases, they are pretty large in others. So what you're all wondering, of course, about is how this study was set up. Well, you just take 150 sleeve patients and measure all sorts of things in their serum. So from vitamins and zinc, ferritin, and many, many more. Then you can either be deficient or non-deficient at all. If you had a deficiency, for example, for, let's say, vitamin D, and it was still persisting after treatment, you were excluded for that specific deficiency. Then afterwards, patients were asked to participate, sign an informed consent, and then were randomized into the 2 groups I mentioned earlier. So you could either get an optimized version or the one with 100% RDA. And then, of course, you were followed in time. The preoperative measurements were already taken, in some cases twice after you were treated for a deficiency, and then after 6 and 12 months. Now, if you take that group as a whole, these are the new deficiencies. So what I mean are the deficiencies that actually developed after having good levels in the first year. And we're going to look at anemia, ferritin, folic acid, vitamin B12, zinc, B1, and B6. There are many more, but these are the most important ones. So this shows you that on average, there are some of the vitamins and minerals that do not give that many deficiencies. But staggeringly, there are some that do. So for example, 15% developed anemia during that first year of the patients that did not have any anemia preoperatively. That is in the range of a gastric bypass. But others do not get that low as after a gastric bypass. So for example, ferritin and folic acid are relatively low. But there's even more vitamin B12 deficiencies after sleeve gastrectomy surgery than there are in gastric bypass surgeries. We did a similar study randomizing in between different multivitamins in gastric bypass patients, and the amount of deficiencies there were 22%. But you also see on the right that even some of the vitamins do not get deficient at all. Another concern in current days is hypervitaminosis. I know that some of you are scared to have high levels of vitamin B12 because it might be related to certain types of cancer. And the same goes for problems with high levels of vitamin B1 and vitamin B6, which we call hypervitaminosis. And especially, for example, vitamin B6, even in a regular multivitamin, is too high after sleeve gastrectomy. It leads to 0% of deficiencies, but also 1 in 4 patients with an elevated level. So combining all these de novo deficiencies in total, you will get 34% of patients without any deficiencies and 66% of patients having 1 or more deficiencies. That is 2/3 of your patients that did not have a deficiency, that even with multivitamin use or advice to get at least a multivitamin a day will develop 1 or more deficiencies. So coming back to the significant outcome. So what I'm going to show you here is what is actually significant coming out of that study. And it is little, but I must say that one of the most important ones is, of course, developing anemia. That is 18 versus 3%, which was highly significant. The next one was a little bit disappointing, of course, with 15% of patients having a lowered folic acid level in the optimized group, although there was more folic acid in that multivitamin. And in the end, less patients had elevated PTH levels after using the optimized multivitamin. So we're coming back to that folic acid. I mean, that 15% is something that we have to look at because it also says something about compliance. So how well do these patients follow our advices? And keep in mind that during this study, the patients were reminded much more often than we do as in the general practice to remind them to take their multivitamins. So if you take this graph after 0, 6, and 12 months, first in blue here are the compliance levels of patients taking a regular multivitamin, so the 100% RDA multivitamin. That means that a quarter of patients had so many complaints using the multivitamin or didn't believe in it because costs, of course, normally is a problem, which didn't occur, of course, in this study while they were offered everything for free. But things like nausea or disbelief in developing deficiencies after a gastric sleeve might lead to a lower compliance level. This even was a little bit, but not significantly lower in the group using the specialized multivitamins. And we know, for example, that if you put in higher amounts of iron or B vitamins, that the aftertaste or the nausea might become a little bit worse. So you have to technically challenge yourself to come up, for example, with better capsules. Now, what we do have is, in terms of statistics, we have a golden spreadsheet, so to speak, because we have 2 variants and we know what delta serum levels did during that year. So, for example, if you would look at the values in negative serum levels for the optimized product compared to the 100% RDA, you know, at least in the compliant patients, how much they drop down after 6 and 12 months. And that also means that you can calculate what actually should have been in it to make sure that the amount of deficiencies, or at least the delta serum levels, remain 0. So if you developed an optimized 2.0, what would that differ from what we use in this study? Now you can calculate that on average you need an additional ferrous fumarate of 38%, leading up to 28 milligrams of ferrous fumarate containing in that new multivitamin. But especially this one is important. Although you don't need as high levels of vitamin B12 as in gastric bypass patients, we did have to increase the dose a tenfold, so by 1,000% up to 100 milligrams. Now, of course, vitamin B1 or thiamine is important. Many advise you take 10 milligrams, but in the patients who are not vomiting, you only require 2.75 milligrams a day to be assured of non-deficiency. So you have, of course, to instruct your patient if they are vomiting, they have to come back more earlier, but giving or overdosing them with 10 milligrams is way off. And for example, zinc was too low and we had to increase it by almost 50%. So I don't know why that happened, but to come to the conclusions, of course, we go a little bit further than what we said in the article. With what we've seen and what is in the current guidelines, I think that it is time to at least look specifically for sleeve supplementation and update those guidelines based upon the research that has come out in recent years. And for this study, the only thing I want to give you is that a gastric sleeve leads to deficiencies and does require multivitamin use, and in my opinion, lifelong. Thank you so much. And of course, in these very strange times, I want to wish you all the best and keep safe. Whenever there's any questions left that you want to ask me personally, this is my email address, and I will answer them gladly. So thank you for the attention, and I'll go back to Ahmad now.
Thank you, Ido. This was a very clear and presentation. The one thing I wanted to point out within the presentation, you meant in vitamin B12 levels, you meant 100 micrograms rather than milligrams, right?
Sorry, you are 100% correct. I forgot the C in the middle. Excellent.
No worries. So please, if you have any questions, type in your question on the chat section, and we'll go ahead and start the discussion. The first question comes from Dr. Hempens, actually. He raises an interesting point. Did you, in your study, look at the use of PPIs and vitamin deficiencies and correlate according to the use of PPIs if patients were more deficient or less deficient accordingly?
Dr. Hempens, that is Professor Hempens. Actually, that is an excellent question. You are spot on. Of course, PPI use is often regarded as something negative in terms of micronutrients because it even lowers gastric acid levels in our patient, making it harder to cleave off, for example, iron from its substrate. We did not do that sub-analysis in this group, but it is an excellent suggestion actually to do so. What I can tell you is that most of the patients get PPIs for the first 4 to 6 weeks. And we also know that the patients that do not take those, because we use them to let's say the freshly cut tissue is then how do you say, less challenged by the acid. We do know that if patients do not use those PPIs, at least the vitamin B12 levels tend to not slow down as fast in those 4 to 6 weeks than the patients that do take them. So there is probably an effect on at least vitamin B12 levels and perhaps also ferritin, but we did not find that here.
Great, thank you, Ido. Now, in your design, I know it's a double-blinded study, and you mentioned the details of the randomization and the blinding within the group. Now, while reading this study, I notice we always look at males and females probably differently, especially in the younger age menstruating female group. Did you look at those certain populations and compare them to the rest within the two groups or not?
We did do a sub-analysis, but I must say that, of course, we only started off with 2 times 75 patients. They do differ, especially the premenopausal women. We know that they on average have more trouble keeping those ferritin levels up because they tend to lose it during menses, of course. But the groups were too small in this case to come up with any significance. So you would require large cohorts for that to actually see that. We did that in a different study that was published a year before. So if you look up my name, it's by my colleague Dr. Smelt, and also published in Obesity Surgery. We did see that difference. So especially the premenopausal women compared to men and postmenopausal women were more at risk of developing deficiencies. So probably that will be the same here also. But in this case, the groups were way too small to get any significance.
And looking also into the details, Ido, the iron beforehand, the iron was deficient more in the standard group before the surgery, and were these optimized, corrected, and then later on developed more vitamin deficiencies or not?
If you refer specifically to iron, we tend to use ferritin more. I must say that we put iron in this article just because many other historic articles have published upon iron also. Iron on itself does not say as much as corrected ferritin, at least for serum reactive protein. So we rather look at ferritin levels and delta ferritin than to iron. The ones that were deficient were indeed treated, or even went as far, not in this study, but sometimes we go as far as advising them to postpone, let's say, menstruation using medication. But on average, looking at deltas for ferritin, these did not differ that much, and indeed iron did, but luckily not as much as ferritin did. So we didn't have to exclude that during the logistic regression analysis.
And you raised the compliance issue, which is a huge factor in the vitamin intake and the cause of deficiencies. Did you do anything to enhance compliance within the study, and what were the tools that you used, and did anything make a difference or not?
It is hard to say which of the things made a difference, but first of all, we have to look at ourselves. I think as healthcare professionals, with the amounts of or percentages just given, what was it, 85% recommending multivitamins to this patient group, which is in my mind excellent. I mean, if we would have that rate for everybody, then 85% I would be very happy with. The thing is that you have to continuously tell those patients to take it. So every time you see them, meet them, please keep in mind, always ask whether they still use it, because it's not in our sight. I mean, the only thing that we do is we ask our patients to use it, but we don't see whether they, in a normal setup, would buy it or take it. They do that at home. So even in this study, we did ask patients on every occasion they came in, but that is something we do in general. But we also do know that in a regular setting, on average, those percentages drop down even to 50% after 1 year, and it has to do with all sorts of things. So that's either complaints of the vitamin itself, so that can be let's say nausea or the feeling of getting nauseous, but especially not believing that it helps you prevent deficiencies seems to be one of the factors that makes people quit. So as healthcare professionals, we are, I think, obliged to keep pointing that out to our patients, that they have to use it, because it's a pound foolish. I mean, in any other way, of course, you pay for multivitamins, but at least in the Netherlands, if you have one deficiency and you get treated for that, you can use multivitamins for over 2 years, because those costs do not weigh up to the use of multivitamins.
And you know, we're getting several questions now.
Right.
One is by Dr. Harry Freidenborg. would you recommend an iron infusion post-op to keep the levels up in the first year?
Again, thank you so much, Harry, for that question. I must say that in Europe, on average, well, not all countries, because, for example, in Switzerland, I know they IV everybody with iron. In the Netherlands, we're used to start off with tablets, and I was a strong believer in supplementing with, for example, losferone, because it seems to up your levels quite okay. The problem only is that patients that do get deficient for ferritin keep getting deficient. You will not be able to hold that off for another year. So 75% of our patients do require a retreatment just for iron once they have ever become deficient. So nowadays, with IV treatment getting cheaper, I must say that I do prefer giving a 1 gram IV or 1,000 milligrams every year. Then at least I know that they will 75% at least will be able to go through that year without becoming deficient for ferritin. So again, prevention is a big thing, because I also thought that if you were deficient and you would treat it and you're at a good level, then you no longer need anything else than a good multivitamin. But that's not true. Even with 70 milligrams a day, you will still drop down again. And the big issue is that the credo, in my opinion, is for ferritin at least, once deficient, you're always deficient.
That's a great points you raise as well, Ido. One of your co-authors is asking, so we always try to enhance compliance, and one of the ways to enhance compliance is to deliver less pills to the patients that they take. However, is it possible to combine all components in one pill? And also, are there any technical problems to enlarge the dose in one pill?
Yes, there are. It is technically challenging. I must say that 10 years ago, when we started this project, I thought you could put anything into one pill. But I must say that volumes are a thing. For example, magnesium is huge. If you would try to get the amount of magnesium in one tablet or one capsule, you would not be able to swallow it. It's that large, and that's just magnesium. Same goes, for example, for calcium. It's a large molecule, and it tends to bind all sorts of micronutrients. Everybody knows, of course, about iron absorption. So in my opinion, it's very strange to actually put, for example, calcium in the same multivitamin as the rest, because you have to overdose then the rest to compensate for that small amount of calcium you're given. There's only tens of milligrams of calcium in the average multivitamin, and you require 1,000 milligrams or something. So it's a drop on a very large bucket, so to speak. I do see a lot of challenges here. Everything is linked, everything's connected. I don't have it here, but there's a very nice slide we made, or one of my colleagues made, that shows all interactions in between vitamins and minerals. So if you up one, you have to lower the other, etc. So there's so many technical challenges you cannot even imagine, and we don't even have enough time during the rest of the day just to explain it. So getting everything in one capsule, so all micronutrients, will never be possible.
Those are technical challenges, and I know you're helping develop the 2.0, so definitely good luck with that. Now, as more compliant patients take vitamins, do you expect to see more hypervitaminosis? And in your study, what was the correlation between compliance and hypervitaminosis?
There's a couple of things. We had hypervitaminosis for B1 and B6, and especially B6. Some people might know that if it gets to toxic levels, which these patients did not, it will lead down to a nervous breakdown. So your nerves do not work as well as before. So you get tingling hands and feet, and in the worst case, you end up at the ICU unit. That is not the levels, again, that we found, but having that in a chronic way might lead to problems in the long term also. So you don't want to be too low, but you don't want to be too high either. And what we found was a possible relation, or it was not significant, but a possible relation in between the two. Again, the groups for that were relatively too small. But from another study, we know that there's another problem, and that is the B6 that is in different food types. So we had a strong relation, for example, with people drinking energy drinks. So like, I don't know whether I'm allowed to mention the name here, but for example, Red Bull contains so high levels of vitamin B6 that it is guaranteed that those patients will get too high levels of B6 in their system if they take 1 can a day. So yes, there's a relation with the amount in a multivitamin. It even tends to be picked up easier after a sleeve than in a regular system. But I must say that many of the patients do have elevated levels also for different reasons. So for taking, in my opinion, the wrong food substances.
Great. Now, we're getting several questions and comments. One comment from Dr. Julie Parrott on the topic of thiamine, vitamin B1, and the correlation of the dose to if the patient is vomiting or not. And she is suggesting that other body fluids could cause deficiency, like diarrhea, microbial status, and is it worthwhile to look at the requirement lifelong rather than a standard dose pill? That's one of her comments. And another comment, she's saying she's seeing good results with all vitamins and minerals except for calcium in one pill. However, one dose is potent and can create nausea if not considering how to take multivitamins. Any thoughts you want to share, Ido?
Welcome, Julie. Nice of you watching. You are all, of course, an expert in this field. You've written a lot about it, of course, this subject plays a big role, starting with the first of thiamine in the US. In the ASMBS guidelines, it's still 10 milligrams. What I was referring to is, of course, in this study. So the patients that were B1 deficient all tended to report also vomiting. So and we saw the similar thing in Roux-en-Y gastric bypass patients. Not even looking at diarrhea, bacterial overgrowth, and of course these can be factors also. But if they were factors, then we would have seen them in other patients also. So that one-on-one status for now, also coming from a large cohort of almost 1,000 patients, seems to add up quite significantly. And we don't know whether it's required lifelong, those B1 levels. We do know, however, that the occurrence of thiamine deficiencies are almost always in the first 6 months, because they are probably related to that vomiting and that postoperative status also, and you don't see them that often in the long term. So it might even be that those, let's say 2.75 milligrams in the long term can even be lower than that. But I do not personally believe that you require a larger dose in future patients, so after 1 year. And we've, of course, enlarged this study already, and the first results, 3-year results, do not show any B1 deficiencies currently, even after 3 years. But excellent question. I know that's a hot topic, and but I always think that on the one hand you don't want to give too little, but on the other hand you don't want to overdose, because overdosing B1 on average does not result in that many problems, because you lose it by urine if it gets too high. On the other hand, if it's not necessary, it's not necessary.
Great. And a question about calcium, and we'll get to the final recommendation as well from you, but the calcium point.
The calcium point. Yeah, well, the thing is that multivitamins have always been, even those are always been developed on historical ways of developing multivitamins. And one of those was to always put calcium in a multivitamin, which, if you look at it now with the knowledge that we have now, does not make any sense, because it's a very small portion and you can get it out. One of the theories there even is that all our patients on average that get operated do have a very large bone mass density. So they would have sufficient calcium in their bone mass to last for a very long time, perhaps in some cases even the rest of their lives. But they're losing it because of low vitamin D levels, magnesium, for example. So you could also try to up the vitamin D and see what happens. We don't have any intel on that yet, but it seems that if you overdose, in between brackets, vitamin D, you might even not need the amounts of calcium that I just told you about. But so far, this is our advice, and it seems to work well.
Now, several questions on the vitamin levels and hypervitaminosis, and how many months would you tolerate a high level, and how frequent do you check the levels to ensure that you're not going within the toxic level?
Right, excellent question. Well, the thing is, let's take vitamin B6 as an example. I must say that we did not expect, of course, for example, in this study, that B6 levels would become that high. I would assume that if you find a high level, then it on average needs to be 10 times as high before it becomes toxic. So what you want to know is whether it gets to those toxic levels, right? And you know, if you would measure at 0 and it's a normal level, it rises at 6, it rises at 12. Every 2 measurements with 6 months in betweens for vitamin B6 is sufficient. So I would say until you see a flattened curve in 3 measurements, then you're fine. On the other hand, of course, you can very shortly stop using the multivitamins, because vitamin B6 within a couple of weeks will drop down, and at least you can see whether the vitamin B6 comes from that multivitamin. But you really have to restart then afterwards, because most of the times you will see that hypervitaminosis comes from something different, like the use of certain food products.
Great. My coach here, Dr. Abdurrahman Numeiri, sends his best regards and asks you a couple questions. Why do you correct for ferritin, and why is iron not good in comparison to ferritin?
Well, ferritin, simple said, thank you, by the way, Dr. Abdelrahman, very nice of you to be here also. Ferritin is actually the, let's say, form of iron that you can that is available for use. So iron on average is more easily said. It also involves a lot of iron that is not there for immediate use. So ferritin says something, for example, on how well your body is capable of producing hemoglobin. For iron itself, you need a couple of other measurements. So you need total iron binding capacity, for example, and you have to correct that to come up with a number. So you have to combine certain measurements, and the best way of doing it is to measure all 4 or 5 of those, and then do the standardized formula to come up with true deficiencies. But from a clinical setting point, it is easiest to only have the most important one, and that's ferritin. And I know there's a lot of different opinions on it, but most endocrinologists mostly look at ferritin just to see whether a patient is acutely deficient or still has some reserves.
Great. And I think we'll end up with this question before we finish and finalize and see if this presentation changed the minds of surgeons on what to use vitamins and in sleeve gastrectomy patients. Do you see a correlation between the sleeve size, bougie size, and vitamin deficiencies or not?
I could not tell you, to be honest, because in this study, of course, we used one center with a standardized procedure using a 40 French bougie, so I know it for this part. The funny thing is that coming up with this, we did a retrospective study in the patients that did this as a first step towards a BPDDS. I can tell you those were much heavier, of course. They had BMIs 10, 15 points higher than this, and you saw also a larger number of deficiencies in those patients. They did have, well, let's say less tight sleeves performed. But you can at least theoretically imagine that if you would have more room to spare, there'd probably be more acid available. But this is pure speculating. So it might be that the broader, how do you say, the wider sleeves might have less deficiencies because they can ingest more foods and cleave it off better than patients that have a very tight sleeve. On the other hand, it's always a fine line in between what you want to achieve as a surgeon in terms of excess weight loss, comorbidity loss, any amount of deficiencies that you have to correct, of course. So what I would put it in the other way is that if you do a sleeve, at least do the best for your patient and advise a multivitamin.
Great. So the final message, the final point you want to deliver to the audience on what to do preoperatively and how do you supplement your patients and how would you advise supplementing sleeve gastrectomy patients?
So my advice would be to at least use a multivitamin. That's the minimum. So if colleagues still tell me they're using nothing or advising nothing, well, that's in my opinion terrible. So we would advise, or I would advise, a specialized multivitamin with addition of calcium D 2 times a day, 500 milligrams, 800 international units of vitamin D, and then 2 hours in between. That is the preventive supplementation I would advise my patients.
Great. So let's launch the polls again and see if you manage to change the audience mind or not. Manuela? So I guess we had to redo the polls again, but hopefully your presentation changed your minds. I know there are a lot of questions that we did not get to. My apologies because of the time constraints, but Ido, thank you very much for this very important and insightful presentation. And I think it's a very important message that you deliver is not even with increasing the vitamin dose, still we face deficiencies, and long-term follow-up is a must. And a final note to surgeons who say we do not give vitamins beyond 6 months, what would you say?
Well, the thing is that most of the deficiencies we only saw after 6 months. So if my advice would be, if you're not convinced still, start measuring. Just start measuring all your patients, and you will see within a year that it's better to supplement your patients for the long term and not just for 6 months.
So thank you, Ido. Thank you for your important talk. I was filling in for Zahir Toumi, who unfortunately could not join us because of an emergency surgery. Hopefully he's doing well, and his patient is doing well as well. Thank you, and hopefully we'll see you again next month.
Thank you so much, Ahmad. All the best to everybody, and keep safe. Bye-bye.
Thank you.